set?
Yep, you got the notification, so we should be good to go.
All right, so you should all see my screen now. So foreign bodies and ingestions, always the first lecture that I give every academic year, because 90% of our foreign bodies usually present in July for some, I don't know, reason. Maybe that's because it's a stress test. So we're going to talk about foreign bodies and ingestions and how we manage them and what the outcomes are. And so let's get right to it. So take out your pencil and paper, and I want you to answer the following question. You receive a call from the emergency department at 11 o'clock on New Year's Eve. 5 patients have presented with foreign body ingestions. Not an unusual scenario, not real common, but it happens. In which order should these be removed? Number 1, a 1999 penny in the stomach of an 18-month-old toddler. 2, a AAA battery in the stomach of a 4-year-old. 3, a button battery in the mid-esophagus of a 2-year-old who was asymptomatic. 4, a quarter in the esophagus of a 3-year-old who vomited twice and is refusing solids. And 5, a toothbrush in the stomach of an asymptomatic 16-year-old bulimic, which he swallowed 2 hours ago. I should tell you, before you answer this question, I have seen all of these, some more than once, obviously. So write down the order in which you would remove them, and we'll get back to this at the end of the lecture. So I'll give you a few seconds. Okay, so let's move on. So, where is the foreign body in the left panel, and where is the foreign body in the right panel?
You mean what anatomical structure is it in?
What anatomical structure is it in? Well, if you're going to endoscopically look at these films, are either of them endoscopically retrievable? Well, the fact is probably not. So here on the left, this is in the right lower quadrant. How are you going to get it? All right. This is probably in the colon. Probably in the colon. And this one, here's your stomach bubble. And assuming the stomach is here, this is more likely in the small bowel at this point. So both of these would be a family that brought their child in probably several hours after the ingestion. And you're just confirming the positioning of the coin, all right? Where is this? Where is this and, oh, sorry. Where is this and what is it?
It's in the esophagus.
Why is it in the esophagus?
Because it's behind the, oh.
Where'd it get stuck?
How can you tell on an AP film that something is in the esophagus or in the trachea? So these are principles you have to know, right? Because the approach is going to be quite different. What does it tell you when you have what's called an en face appearance? Where is that?
I would think that implies it's in the esophagus because
that's in the esophagus.
Is too small to have it be en face in the esophagus and stretch out.
I guarantee you that 9 out of every 10 foreign bodies you remove from the esophagus are right at the level of the clavicles. because that's right at the level of where the upper esophageal sphincter is, and that's where they get stuck. So on FOS, on a PA, on edge, on a lateral. But what is this?
Well, it's most likely a coin. It doesn't appear to have a double rim sign that would imply it's a button battery. But of course,
like that?
Yes, like that. That
like
is
that.
Definitely a button battery.
Okay. That's definitely a button battery. Absolutely. And this is a button battery that's in the mid to lower esophagus, which is sort of an unusual place for these foreign bodies to hide. But there it is. All right. So here's your critical investigational skills first. When you see this rim here, the step off, that's the clue that this is a battery, not a coin. These are so-called poppet beads, right? I've seen all of these things, so there's nothing new under the sun.
That image is raising my blood pressure.
I'll get you one that'll really raise your blood pressure.
Thanks.
I like
that?
even worse
Oh,
the
God.
new version with the super tiny magnets and balls, the ones that they make bracelets out of.
Oh, I
Uh,
have
I spent
well,
spent hours getting those out of a kid's stomach and eventually used a magnetized probe.
Hold that
wow.
thought, hold that thought, Dr. Wallach. Hold that thought. What's this?
It's a pair of magnets.
Those are two magnets, right? Fortunately, these two magnets are together. All right? All right. Oop. What's that?
That could also be two magnets stuck together or an
Well-
Oreo covered in barium.
Well, those happen to be two AAA batteries.
Oh.
Okay. This is just show and tell. Now, Dr. Wallach, this was my patient. This is a 17-month-old. Where is this? Sometimes it's hard to tell on a film. This is in the stomach. What is this?
Bracelet?
It's a bracelet. What's the bracelet made out of?
Likely a metallic bead.
No, this is made out of buckyball magnets.
Nightmare fuel.
Ah.
Right? So, how are you going to take this out?
Are they connected by a string or is it just a
No,
magnet?
they're not connected by a string. They're connected only by magnetic force. Well, it was actually, what we tried to do is we saw the bracelet and we tried to take it out with a forceps, thinking that the beads were connected by a string. But every time we tried to, grab it, we grabbed nothing because there was nothing between the magnets. So my fellow at the time, the famous Dr. Esther Prince, said to me, Dr. Schwarz, why don't we try a Rothnet? And what we did was we took the Rothnet, put it in, grabbed two of the beads, and everything else just followed. We pulled the whole thing out in one pass.
Excellent.
This film was on CNN, by the way. We made it to CNN pulling this out. There were 29, you can count them, 29 magnets. Had this passed the pylorus, what would happen, Bryce?
Well, it could have been broken up by the peristaltic action of the intestine. It could have ended up in segments.
It's unlikely that it's going to be broken up, but what's going to happen is that it's going to make a loop, and then you may get magnets opposed to each other, leading to them getting magnetic force pushing them together, and that could result with entrapped
Necrosis of the
bowel
tissue.
between the magnets, leading to necrosis. And that is the danger when one ingests these magnets. So, more than 80% of foreign body ingestions are in pediatric patients. Most cases are in children less than 3 years of age. Most cases that receive medical attention have been witnessed, and the remainder are found incidentally, either a radiologic evaluation or a foreign body is seen in the stool or in the diaper. Because most of these things are witnessed, are not witnessed, the real incidence is unknown. But as far back as 2000, there were more than 100,000 ED cases of foreign bodies that were reported in the US. 98% of these ingestions are unintentional. A child is playing with something in the mouth and oops, I swallowed it. So the types of foreign body in the US, if we go from most common to least common, coins would be the most common, then toy parts, sharps, batteries, chicken or fish bones, food impaction. Chicken or fish bones are interesting. I always used, when I was a resident and a fellow, I always used to carry with me an alligator forceps, because the chicken or fish bones typically get lodged in the posterior pharynx. And you can have the patient open the mouth and you can reach in and pull it out. So that's just something of interest. And of course, food impaction, which we now know is a common complication of eosinophilic esophagitis. In adolescents and adults, foreign body ingestions are very common in psychiatric patients. In patients without a psychiatric history, meat impaction would be the most common. And if you have an individual who either is anorexia or bulimia, toothbrushes, and other instruments used to induce vomiting. And this is how I got a call one night from Kings County that they had a 15-year-old who was bulimic, who was trying to promote emesis using a 9-inch long toothbrush and swallowed the toothbrush. And it was in the stomach. And we got in, we couldn't get it out because there was nothing to grab. And she ended up having to have gastrotomy to take out the toothbrush. So it happens.
So quick question with that. Were I would think that the bristles would be relatively easy to grab with forceps, something that would hang on to them. Was it, did that not work? Or
if you think about it, what are you going to grab? Well, you can snare it, but when you snare it, what happens is whatever you snare, the long axis is going to be perpendicular to the snare.
Right.
Because of that way, how are you going to pull it out that way? The only way to really pull it out that way is some of these toothbrushes have a hole at the end of the handle.
Mm-hmm.
So you can grab it from the end, which we couldn't do because it did not have a hole at the end of the handle, and the handle was too thick for anything to grab there, or the head of the toothbrush. But if you try to grab it anyplace else, it's like pulling it out.
Right.
You know, if you can't do it.
I wonder if you could try like maneuvering it into an over tube so that it would be anyway.
Right. You can use, if you have access to an over tube, which they didn't have, that's when you can do it.
Thank you.
So what are the symptoms? Well, the symptoms of a foreign body ingestion: type, location, patient size, duration. The longer a foreign body is in, the more likely it is to cause at least pressure necrosis, making it more difficult to take out. Oropharyngeal foreign bodies like bones are almost always symptomatic. And obviously, as I said, it's usually the posterior pharynx, and if left in for a long period of time, may result in a retropharyngeal abscess. In young children who have esophageal foreign bodies, it's not uncommon for them to have choking, drooling, or just solid food refusal. And they can also, an esophageal foreign body can also induce respiratory symptoms reflexively. So they can actually come in wheezing even if the foreign body's in the esophagus. In older children, dysphagia, odynophagia, and chest pain would be the more common symptoms.
Can I
Keep in
add
mind,
something?
excuse me?
Sorry, I was going to say, can I add something?
Of course.
It's important to have a really high index of suspicion in those younger kids because they can and will swallow anything and everything, and not everything will show up on an X-ray.
Right.
So if you get an X-ray and there's nothing, but this kid is still like refusing to take PO or in distress and crying, sometimes it's worth just going in and looking. Like we had a kid like that when I was a fellow who had swallowed a sort of like rigid, clear plastic tag that was lodged in his esophagus, and we were never going to see it on an X-ray, but
Right.
it needed to be taken out.
And it's, for a small child to do an ultrasound can be a difficult thing to do as well. So Dr. Levine is 100% correct. Keep in mind that if a foreign body is in the proximal third of the esophagus, the location of pain does not correlate with the site. Usually, objects that cause pain in the proximal third of the esophagus, if the patient is in pain, they may point to their neck. In the distal 2/3 of the esophagus, wherever they're pointing, that's where the problem is. So, in the stomach or small intestine, once something gets there, it's usually asymptomatic. Obstructive symptoms are very rare. When that occurs, it's the ball valve effect, usually at the level of the pylorus. And of course, perforations are always the thing we worry about with sharp objects, depending upon what the sharp object is and how long that object is. And we'll talk more about that. In the oropharynx, 5 to 10% of the foreign bodies, higher again if it's a fishbone. Esophagus, 20%, stomach, 60%, and distal to the stomach, 10%. Now, Dr. Levine talked about radiolucent objects, but up to 90% of these objects are going to be radioopaque. And therefore, it's recommended that you get an X-ray in every case of a suspected foreign body ingestion. Again, if something is lodged in the esophagus, even if it's a benign kind of object, the longer it stays there, the more likely it's going to cause injury from pressure necrosis.
And practically speaking, when you're talking to the ER, a lot of places have a foreign body series, which is great because it includes multiple views. But if they don't, or you don't know, make sure that they're getting at least 2 views so that can help you localize where it is. Because it can look like something's in the stomach, but it's in the small intestine. And you need more than 1 view to figure it out.
Correct. The natural history of these are 80 to 90% pass spontaneously. And only up to 20% require endoscopic removal. And as long as I've been doing this, which is now, I don't do it anymore, but the only patient I ran into who required surgical removal was that 15-year-old with the toothbrush. Other than that, if it was in the stomach or the esophagus, we were always able to get it out. So this is an article that appeared in JPGN in 2015. Things really haven't changed since then on the management of ingested foreign bodies. So again, let's start with coin ingestion. More than 20,000 ED visits per year by children. radiography, and again, chest, abdomen, lateral neck, at very least, PA and lateral. Remember again that esophageal foreign bodies tend to have an en-face appearance, tracheal foreign bodies an on-edge appearance, but I have seen a tracheal foreign body with an en-face appearance. So nothing is absolute. And again, esophageal coins may cause respiratory symptoms via tracheal compression, and that's usually as a result of prolonged retention with some element of necrosis and esophageal wall edema. In the esophagus, 60 to 70% of foreign bodies will be at the upper esophageal sphincter or the thoracic inlet, 10 to 20% in the mid-esophagus, 20% in the lower esophageal sphincter. Now, looking at these three locations, what worries you about the mid-esophagus and LES location? Anyone? Aside from your attendings?
In relation to their relationship with other anatomical structures that could be impacted?
Well, right. So if something is lodged in the mid-esophagus or lower esophageal sphincter, you have to be very mindful of the fact that foreign bodies impacted in these locations are more likely to be associated with some esophageal abnormality. Eosinophilic esophagitis, reflux esophagitis with edema, Schatzky ring, a web or membrane. When it's in the UES or thoracic inlet, that's really very unlikely to be associated with esophageal pathology. But the lower down in the esophagus you go, especially in the mid-esophagus, you really are worried about esophageal pathology. So when you take out a foreign body from the mid-esophagus or lower esophageal area, you go back in again, you take a very careful look, and probably also would not be remiss in biopsying, depending upon the status of the esophagus at the time, because you really are concerned about associated esophageal pathology. So if you continue reading on this slide, there's an increased risk of lodging in the mid-esophagus and lower esophageal sphincter if there's underlying esophageal disease, previous injury, or the patient has had esophageal surgery, such as for a tracheoesophageal fistula, or fundoplication. So these are very important to remember this when approaching these objects.
May I add something as well?
Of course.
The other part of the evaluation that's critical, especially if it's in the mid-esophagus, and especially if there's not a good history that it has been just recently, the potential there is that it's being held up by the aortic arch, and if it's in there for a while, the possibility of an esophageal aortic fistula. We had a kid that surgery in the good old days went in and took out in the Kings County, and when the kid came to the ICU afterwards, he bled out because of the fistula. So in those situations, it's very prudent to have some type of cardiothoracic individual available if need be right away.
Yeah, I think that situation is probably more relevant to a battery that's been in for a long time. But I think you can judge on the basis of when you go in, particularly in the area of the aortic arch, if there is any evidence of pressure necrosis or other esophageal damage, then you have to consider that. Where is this? What is it and where is it? Well, this is a typical coin that's lodged in the upper esophageal sphincter, and this is what it looks like. It's not like a big open structure with this thing staring you in the face. You just see the on edge appearance of the coin.
You can see
So
it
how
has
do we-
a fluted edge too, so I guess it's a quarter or a dime and not a nickel, right?
You have at this point, this is probably a quarter, because I can see the ridges. A nickel would be very smooth, and
Right.
this is bigger than a dime. So I think this is probably a quarter, but it could be a nickel, but it's probably a quarter.
And this, of course, matters for tax deduction reasons.
Yeah.
Yeah, it's a tip for the pathologist.
I
Exactly.
once removed an old shilling coin.
Okay, so symptomatic patients, emergent endoscopic removal for those who are unable to swallow secretions or who have respiratory symptoms. If the patient can swallow secretions, 12 to 24 hours observation, 1/3 will pass spontaneously, especially distal esophageal coins. So this is typical for the foreign body that's in the mid-esophagus. Very rarely, I've never seen a child who had an upper esophageal sphincter lodged object that we didn't have to take it out right away. But the lower down it goes, they may be able to swallow secretions. And with delayed endoscopy, there's a higher risk of aspiration. Basically, if a patient in the second scenario comes in at night, we'll schedule endoscopy for the next morning, and that's fine. If the patient comes in, early in the morning, you may accelerate it and move it up. So it's really a question of you talking to the parents, assessing the patient, and making a decision. All right, and this is how we remove it. All right, this is how we remove it. I like to use a rat tooth forceps. Alligator forceps are also good, and just get a good grip and you just slowly pull it out. Now you can see here, this is not normal. So this has probably been in for a while and has already caused some local injury.
The other thing I'll sometimes do when I'm removing a coin or something from the esophagus is ask anesthesiologist to have a McGill forceps handy, because sometimes as you're navigating the hypopharynx or the oropharynx, the coin will pop off and they can just grab it with the McGill, or it'll pop off like if you forget to take the bite block out or something like that, it'll be in the mouth and they can just grab it for you.
By the way, do you use an LMA or mask anesthesia for these patients?
No, you definitely want to intubate them.
You definitely want to intubate them. That was a trick question. You intubate because the one thing you don't want, as Dr. Levine mentioned, is to have this thing slip off and then go into the trachea. So yes, they are all intubated. Asymptomatic, don't wait more than 24 hours before removal. If it's a foreign body that the foreign body itself demands immediate removal, which in most cases would be either a sharp or a button battery. If you retain the foreign body for a prolonged period of time, you risk complications such as stricture, tracheal compression, as Dr. Rabinowitz mentioned, aortoesophageal fistulae, the development of a diverticulum or pseudodiverticulum of the esophagus, a mediastinitis, and then obviously a tracheo or bronchoesophageal fistula. I've seen an aortoesophageal. I've seen an aortoesophageal fistula. I've never seen a diverticulum. I have seen mediastinitis, and so you've got to be very mindful of the fact you don't leave these things in for more than 24 hours under any circumstance. That's why this is what happens for a foreign body that's been retained for a long period of time. It's causing significant pressure necrosis of the tissue. And you could see exactly where the foreign body was aligned. Yeah. One edge here, one edge there. What about gastric or more distal coins? Well, we remove them only if the patient is symptomatic or it's been retained for several weeks. And obviously, depending upon what instrumentation you have access to, this may require surgical removal. Fortunately, most will be expelled in 4 to 6 days. 40% will not be detected in the stool. They just disappear. Do not use prokinetics. And in asymptomatic patients, you want to get a follow-up film at 2 to 3 weeks. If at 2 to 3 weeks, the foreign body is still there, it's unlikely to move. And so in a gastric foreign body, if something has been there for a couple of weeks, I will tend to remove it. Those that pass the pylorus, where are they most likely to get lodged?
I guess the ileocecal valve.
The ileocecal valve. And so the patients you worry about would be those patients who have ileocecal valve disease, which our population would be patients with Crohn's disease. Fortunately, patients with Crohn's disease are rarely toddlers. So the fact is, we don't have a lot of our IBD patients ingesting foreign bodies. If they did, we'd probably see ileocecal impaction more frequently. I've never seen it in a patient with IBD because these are older patients and they don't go along swallowing foreign bodies.
The other place I've seen things get stuck is actually the appendix, which can mimic appendicitis, surprisingly enough.
Right. So gastricoins that are symptomatic, prompt removal, they're usually symptomatic because the pylorus becomes obstructed. People talk about pennies, which until 1982, zinc was the predominant metal. Thus, it was told that there was a potential for zinc toxicity. No one has ever seen zinc toxicity with these old pennies, which are not in circulation anymore, so it's a non-issue. Okay, so this is a gastric foreign body, gastric coin, and this is being removed by a Rothnet. And that's the way you take them out in the stomach. You don't take them out with a forceps when they're in the stomach. Why not? Think about anatomy. So you're grabbing a foreign body in the stomach. Where do you have to pull it through?
Through the lower esophageal sphincter. And then
Through the lower esophageal sphincter. Is the lower esophageal sphincter normally open or closed?
It's normally closed.
Normally closed. Well, you've got a scope going down through there, so you're forcing it open.
Right.
But if you try to take out a coin, well, maybe you'll get a dime through. If you're trying to take out a coin from the stomach using a forceps, it's going to slip off. High likelihood of slipping off once it gets to the level of the LES. That's why we use a Rothnet. And the other reason, as Dr. Levine mentioned also, you've got to traverse a pretty far distance. The farther you have to drag the foreign body, the higher the risk of it falling off if you're grabbing it with a forceps. With a Rothnet, it's there. It's not going to move. It's not going to get lost. You'll pull it out. I'm sorry, Annie, you were saying something?
Oh, what I was going to say is fellows who've scoped with me know that the reason that I make you practice your retroflexion so much is that foreign bodies also like to hide up in the cardia.
Right.
And so you have to get used to navigating that area when you're taking foreign bodies out. And it can be really tricky to get stuff when it's hiding up there. And so
again,
practice
grabbing
every
it with the Rothnet could be difficult when with extreme recreflection. Sometimes you'll use a forceps to try to move the object and then grab it with the Rothnet. All of these cases are really individual, and you have to be prepared for a lot of wacky stuff endoscopically. So you have to have an attending with you who guide you through the process. But it's interesting. And again, think of the anatomy of the stomach, think how the patient is positioned, and you can see why it's going to hide up well up in the body and in the cardia as well. So they're not always staring at you when you go in endoscopically when they're in the stomach.
One little trick that is relevant for this area comes into play when you have a gastrostomy tube that you're taking out. So you cut it, and then you have your loop, and you grab onto it. So the way that it's positioned, oftentimes, depending on how close or not close you get to the end, you have a perpendicular body going through, as Dr. Schwarz points out, the LES and then the UES. And one thing that can help you to do that, actually Dr. Khan, who's not on the saw it with me the last time, is we give extra air and you very, very slightly twist your wrist so that rather than pushing directly, you're kind of torquing it through the sphincter as it opens up with the blowing of the air.
Well, the thing with this, when you're taking out a gastrostomy, you're taking out essentially a flexible tube, so that it's less of an issue getting it through. But that's for another day. Okay, coins past the pylorus will pass largely without difficulty, and again, potential sites of obstruction, Meckel's or the appendix, a site of prior surgery in the ileocecal valve. So here we have everything in review. We have the coin ingestion, PA and lateral films. Ensure it's not a button battery. If it's esophageal, asymptomatic, removal within 24 hours. Glucagon, I've not used it. The one thing in an asymptomatic patient that has worked is to give them a little Coca-Cola or ginger ale, because sometimes the swallowing of the bubbles puts enough air into the esophagus that it opens up and the thing will pass. So I've tried that. It's worked a couple of times, and it's probably worth trying. If the patient is symptomatic, drooling, dysphagia, respiratory compromise, urgently. Gastric foreign bodies, no endoscopy needed. Consider straining the stools, X-ray at 2 weeks. Endoscopic removal if not passed within 2 to 4 weeks. And always, when you admit somebody for a foreign body, get a film right before you're going to remove it. Because sometimes, and I've been there and I've done that, sometimes I go in and there's nothing there because on the way from when they admit it to the hospital to the time they get to the OR, it passes. So make sure you get one right before you go in. In the small bowel, just observation and removal if symptomatic. All right. As we mentioned earlier, this is a coin, and this is what we don't want to see. I'm sorry, this is a button battery. I'm sorry. The button battery, you can tell by the step-off design. And again, this is what you don't want to see. This is the worst case scenario for a patient like this. This is the patient that you're not going to touch them until you have cardiothoracic surgery in the room. All right?
And at downstate, that means you have transferred them elsewhere.
That's what it means. That's what it means.
Two different things. Dr. Schwarz, go back if you wouldn't mind, just to show the fellows the one back four and point out that ridge over there.
I did initially. This is the second time I've shown it. Okay.
Then the other part is that when you get a phone call from the emergency room that they're bringing a kid to be having a foreign body removed from a place like Coney Island Hospital, you absolutely positively must ascertain that this is not a button battery, because I was in that situation.
What you need to do, if it's a foreign body, they need to send you the film. And once they send you the film, then you can marshal your resources. All right. So esophageal button batteries have emerged as the most critical indication for emergent endoscopy in children. The high degree of morbidity and mortality that has been observed with them has led to renewed focus to determine the optimal management of these children. And the types of injuries: tracheoesophageal fistula, esophageal perforation, strictures, vocal cord paralysis from recurrent laryngeal nerve injury, mediastinitis, cardiac arrest, pneumothorax, and aortoenteric fistula. And 7 out of 13 fatalities followed that last set of complications. This is one of our patients when I first got to downstate. This is a sagittal MRI demonstrating inflammation extending anteriorly from the esophagus into the immediate proximity of the aortic arch, following removal of an impacted button battery in the mid-esophagus. So these are common ingestions in young children. Button batteries are ingested more commonly than cylindrical because they look more like a piece of candy. Symptoms are only in 3 to 10% of cases, and their morbidity is related to esophageal location, even in asymptomatic patients. Get an immediate X-ray, and the management is going to be based on location and size. If it's esophageal, remove it immediately. Perforations have been reported within 6 hours, leading to tracheoesophageal fistulae. Esophageal strictures have been noted for batteries in place up to for as little as 10 hours. And most of these complications are with larger batteries, those that are greater than 20 millimeters in diameter. However, injury has also been reported in smaller batteries. The reason that there are more complications with large batteries is that they are more likely to stay lodged in the esophagus. Smaller ones are likely to pass. Gastric batteries, asymptomatic, and observed for smaller batteries. For batteries greater than 15 millimeters, there's decreased spontaneous passage, and you want to remove them after no more than 48 hours. I would state the following, again, to modify this. Any button battery that's in the stomach for longer than 24 hours needs to be removed. I think use that as the golden rule, and you'll be very safe. Because although the risk of injury is much less, it still can occur. Of course, if a patient is symptomatic, doesn't matter where the location is, get it out. Complications from gastric batteries are much less likely, but includes gastric ulceration. When these foreign bodies are in the stomach for a long period of time, they act like a foreign body. They get a foreign body reaction, and they actually become embedded within the mucosa. Mercury poisoning has not been reported, of course. We don't have mercury batteries anymore. They're lithium ion, so that's not a consideration. So, witnessed or suspected button battery ingestion. Esophageal, immediate endoscopic removal. Actively bleeding or a patient who's clinically unstable, endoscopic removal in the OR with surgery and cardiovascular surgery present. So again, anything other than 100% stability of the patient, you want to have surgery present. If evidence of any esophageal injury, admit NPO IV antibiotics. Consider CT angiography to exclude aortic injury. consider an MRI of the chest to determine the proximity of injury to the aorta. If there's injury close to the aorta, continue the patient NPO and antibiotic therapy, and a serial MRI every 5 to 7 days until the injury is seen to recede from the aorta. If there's the presence of hematemesis or upper GI bleeding within 21 days of removal, assume an aortoenteric fistula, and that's emergency. So I've never gone that far, but these are the things you have to worry about. If there's no significant injury to the tissue or proximity of the aorta, you want to do, for a prolonged ingestion, an esophagram to exclude a leak before advancing the diet. Now, Bryce, they call you from Coney Island Hospital. They got a kid there who ingested a button battery. Kid is asymptomatic. It's in the esophagus. It'll take them an hour to get the patient to downstate. What are you going to have them do?
Well, I'm probably going to be inclined to transfer them to someplace with CT surgery, but if it was witnessed and it's going to take them an hour and I can have everything set up, it might just be within the window to take care of it early on. But
That's not the answer I was looking for.
Okay.
How are you going to manage the patient?
Honey? Have them swallow honey? Because honey's dielectric, so that will help to prevent corrosive damage.
All right. Anything else you can do to limit the injury, potential injury?
Besides having them be NPO, except for the honey.
Oh, except for what?
The honey.
The honey.
Yeah. So I've been saying that. I guess my audio is really bad. Sorry.
Yeah, honey. Yes. How much honey do you give?
I would want to give not enough to induce symptoms and choking because they have, but enough.
The rule of thumb is 10 milliliters every 10 minutes. But, and why does honey work?
Because it's an insulator. It's a dielectric. Can anybody hear me?
It's also acidic. So this is what I want you to do. One of the fellows, for a future session, I want you to collect all the literature on the use of honey for button battery ingestions, and let's go over it, okay? I think that would be a good thing to review, all right? So for gastric foreign bodies or beyond, if it's less than 20 millimeters, you may observe them as an outpatient, repeat the x-ray, I would say within 24 to 48 hours. If it doesn't pass, and if it's beyond the pylorus, it'll pass. But if it remains in the stomach for more than 24 hours, it should be removed. Again, for young patients with a button battery greater than 20 millimeters in diameter, you are probably going to have to remove them. I would then, for those patients, probably, given our population, probably admit them and then observe for 24 hours. And if the battery is still in the stomach, which is likely to be if it's greater than 20 millimeters, go ahead and get it out. Meat impaction is something that occurs in older children and adolescents primarily. It is the most common foreign body in adults. 95% of those who develop a meat impaction have underlying esophageal pathology. X-ray, no contrast, and you don't want to use any contrast because it's going to pool above the impaction and increase the risk of aspiration. And Dr. Rabinowitz will go into this much more in depth when he discusses eosinophilic esophagitis, which that is, all right? So when you have a meat impaction, again, these are one of these patients. If they can swallow secretions, I will try the Coca-Cola trick, see if that works. If they can't handle secretions, they need to be scoped immediately. Don't use meat tenderizers. That's a favorite board question. Should we give a meat tenderizer? Well, when you give a meat tenderizer to someone with a meat impaction, you're most likely to tenderize the esophagus, and you really don't want to do that. And these meat tenderizers are very high in sodium, so you can induce hypernatremia. Avoid pushing meat into the stomach. Again, if you're an experienced endoscopist and it's not a hard impaction, you can gently try to do this, but only under supervision. On the other hand, gentle air insufflation, hence the Coca-Cola trick, may be sufficient to push it down. If you can do gentle air insufflation and can see a space between the impaction and the esophageal wall, then you may be able to gently push that into the stomach. But I would not do that as a matter of course. It's all in an individual situation. Again, what about sharps? They have increased complication rates, but it depends on the number, the type, and the contact time. All right. The common objects include toothpicks, nails, needles, straight pins, safety pins, and fish bones. All right. What about screws? You get a call from the emergency room. I got a kid who swallowed a 1-inch screw. What are you going to tell him?
I think that's pretty similar to a pin if it's already in the stomach. It's going to probably pass.
It's in the stomach. He's got a 1-inch screw in the stomach. Get it out. He's going to perforate.
Yeah, it's probably going to pass without perforation if it's
Why?
Screw in the stomach. It has a smooth end and a sharp end, and it'll just tend to get through the pylorus and make its own way on through.
Right. Advancing points perforate, trailing points don't. And when you ingest a screw, the head of the screw is always the advancing point. So I've had more than one argument with the emergency physician who would call me in the middle of the night about a small screw that someone ingested. And I said, don't bother me, wake me, send the kid home. But you want to get a chest x-ray, you want to get a KUB, a PA and lateral at least. Even straight pins usually pass uneventfully, and you may defer endoscopy depending on their length. And again, because of a straight pin, it does have a small head on it, and that's going to be the lead point. Where you run into problems is when you have a sewing needle, where there is really no specific leading head. And that is something that you may want to emergently remove. Because size may preclude passage. Ovoid objects greater than 5 centimeters in length or greater than 2 centimeters in thickness are unlikely to pass the pylorus in adolescents, and should be removed. In young children, you want to retrieve ovoid objects greater than 2 centimeters in diameter, certainly. So the timing of esophageal and gastric foreign body removal, emergent is less than 2 hours from presentation, regardless of NPO status. Again, that would be the button battery. If the button battery is there and the patient has eaten, you still want to get it out, and you may have to go in with a nasogastric tube first and empty the stomach. But that's something that's got to come out. If it's urgent, less than 24 hours from presentation. Elective would be greater than 24 hours from presentation. So here's the timing. Here's the emergent, less than 2 hours. Esophageal location, button battery, no delay. Obstructive symptoms, respiratory distress, significant pain, sharp pointed objects, multiple magnets. And if there are multiple magnets in the gastric location, that's emergent. Urgent, esophageal location with minimal symptoms. Gastric location, sharp or longer objects with no symptoms. Non-urgent, in the gastric location where the foreign body is greater than 2 centimeters wide or greater than 5 centimeters long. Now, this is a guide. It's not a Bible. So you really have to judge each case on its own merits before making that decision. Sometimes, it's a discussion with the parents, and they made a demand that you get it out right away. Well, you are to then tell them, what the likelihood, what's going to happen. But in the end, you have to, if you think this foreign body is eventually going to have to come out, the timing becomes less important, except for the emergent, where there is no discussion. Most ingested foreign bodies are best treated with flexible endoscopes, where there's a high success rate. In most cases, endoscopic removal of foreign bodies in children should be performed under general anesthesia with intubation. We mentioned that already. The retrieval devices to be available, rat tooth and alligator forceps, polypectomy snares, they can be very useful, polyp graspers, Dormier baskets, and Roth nets. You should have most of these available to you to take out a foreign body. You may not use them, but it's nice to know that they're there. So, you receive a call from the ED at 11 o'clock p.m. on New Year's Eve. 5 patients are presented with foreign bodies. In which order should they be removed? Number 1. Number 2. Hey guys, this is the answers, all right? Number 1 is the button battery in the mid-esophagus of a 2-year-old who's asymptomatic. Number 2 is a quarter in the esophagus of a 3-year-old who vomited twice and is refusing solids. Number 3 is the AAA battery in the stomach of a 4-year-old. Number 4 is a toothbrush in the stomach of an asymptomatic 16-year-old bulimic, which he swallowed 2 hours ago. And the last one, which you hopefully will never have to take out, is a penny in the stomach of an 18-month-old toddler. All of you, I'm sure, had that order. If you hadn't, think about it, because that's the order. So it's now 2 o'clock. I guess we should save caustic ingestions for next time, Tom?
I think so. Thanks for the great lecture, Steve.
Okay. And also, I want to have which of the fellows, you can assign whichever fellow you want, but I think a review